Hi everyone, I'm Dr. Ilajan Khandelwal and I'm back with the next thing students, that is in this video we are going to discuss the INI-CET pathology questions which were asked in the November 2022 exam, right? Now as you all know students, the paraclinical subjects like pathology and pharmacology are very important for INI-CET. So in this year students, in November 2022 in INI-CET, approximately 25 questions were asked in both the session 1 and session 2 from pathology, right, which is a big number, right? This is without overlap students. If we combine the questions which are asked with the overlaps from other subjects like pharmacology, gynecology, surgery or medicine, then that includes approximately 30 to 32 questions, which is a huge number, right? That also signifies the importance of pathology as a subject, right? Pathology is the core subject students, I always tell you, and if you understand and know pathology in a nice way, then you will be able to answer the questions which are asked from medicine, surgery, gynae, etc., right? As you all know students, if you ask me about the difficulty level, the questions were not very difficult. The questions were easy, and the best part was a lot of PYQs, that is previous year questions, were asked, right? INI-CET exam has this tendency to ask a lot of previous year questions, right? Not just the same question students, but the topics are very important, right? Even if you listen to the interviews of the topper students, you will notice that some of the toppers, what they did was they just noted down the important topics from the previous 3-year questions which are asked in the INI-CET and NEET. That is why my suggestion to all the students who will be appearing for the NEET exam 2023 or next year INI-CET is that please students write down the important topics from the previous 3 to 4 year papers which were asked, and do those topics inside out, because those are the commonly repeated topics, right? The difficulty level in both the session 1 and session 2, that is the morning and evening session, were almost equal, I would say. Some students said that they found the session 2 a little more tougher as compared to session 1, but that is, I think, very subjective. But when we saw the questions, almost similar questions and similar topics were asked. So difficulty level was almost the same. A lot of questions were asked with a clinico-pathologic scenario, which is the trend these days, right? So the take-home point from here is that please do the previous year questions, right? Now, if you ask me about the topic students, these are the topics which were asked in session 1, right? So from general pathology, you all know one of the favorite topic for examination is cellular aging, right? For the past 5 years, this is one of the hottest topic, and every year in NEET or INI-CET, a lot of questions are asked from cellular aging, right? This year also there was a question on sirtuins which was asked. So students who will be appearing for NEET, please do cellular aging in great detail, right? There was another question on atrophy. So there were 2 questions from cellular injury and adaptation chapter. Then inflammation, we had a question on transmigration. From neoplasia, chemical carcinogenesis is one of the hottest topic these days which was asked, and there were a lot of questions on cytokines which were asked. 2 questions on cytokines in both the papers, and 1 question on immunodeficiency disorder, right? Then there was a question on stain, Gaucher's disease, and the image of the Gaucher cell is one of the hottest picture which the examiner asks you. And then there was a question on oncogenes, right? Then when I tell you about hematology students, I always tell you all the 4 types of leukemias and anemias are extremely important. So in this paper we saw that there were questions on each type: ALL, CLL, CML. Then there was a question on hemolytic anemia. There was a question on DD of microcytic hypochromic anemia, that is also very important. Practical hematology, 1 question is always asked. So in session 1 there was 1 question, in session 2 there was another question, right? Then Hodgkin's lymphoma students. Even if you are sleeping, you have to know this topic of Hodgkin's lymphoma. It is this and Burkitt's lymphoma are one of the most important topics, right? So they were also asked. So you can now only you can see that these are the most important topics which we have been telling you that they will be asked in the exams, right? So you can't miss this topic, students. There was a question on hemophilia, and one question was there on thromboelastography. A similar question was asked in NEET exam on the same technique, thromboelastography, right? Now, when I talk about systemic pathology, I always stress upon cancers, right? In systemic, what is important is cancers. And remember, students, thyroid cancer, papillary cancer with orphan ani nuclei, and lung cancers are two very important topics which we have been telling you, and those are the things which were asked this year also. There was an image-based question on molluscum contagiosum, another question on GIST, and a question on familial adenomatous polyposis. So this is the topic distribution in session 1 of the INI-CET November 22 exam, right? Let us see the questions once, and my request to all of you is that write down the topics on the side and just do these things in detail. I have tried to formulate all the important things about these particular topics in this video. So please do watch this video so that you know for the future exams what are the prospective questions, right? So let us start our journey of the important questions which are asked. Now the first question was, a man presented with fever, night sweats, weight loss for 2 months, right? Remember, I told you whenever you have a clinico-pathologic question, what you have to do, students, is you have to mark the important keywords. So there is a person with fever, night sweats, weight loss. On examination, non-tender rubbery lymph nodes were palpable in the supraclavicular and inguinal regions on both sides. Lymph node biopsy showed the presence of binucleated cells, right? So what are the important keywords? A person with fever, night sweats, weight loss. What all will you think of? Simple medicine. I will think of TB. In India, TB is very common, right? Now, when the examiner is telling rubbery lymph node is not seen in TB. Rubbery lymph node is seen in Hodgkin's lymphoma. And which is the most common lymph node which is enlarged in Hodgkin's lymphoma, students? Supraclavicular lymph node, right? So that is cervical lymph nodes, right? Lymph node biopsy shows the binucleated cells. That is the most characteristic thing. Which cell are they talking about, the binucleated cells? They are talking about the Reed-Sternberg cell. That means I confirm that my diagnosis in this question is Hodgkin's lymphoma. Easy question. And this is one of the hottest topic for the examiner, students, that is Hodgkin's lymphoma. Please do this topic in detail, right? Now, what question that they are? What markers will be seen in this condition? What are the markers? Come on, students. I always keep on telling you what are the markers for Hodgkin's lymphoma? CD15 and CD30. They are the markers for classical Hodgkin's lymphoma. Let us see the question. CD15, CD30, CD19, CD3. Both CD19 and CD3 are absent. That is why the answer is 1 and 2. The answer is D. Understood, students? Easy, right? So this was a question on Hodgkin's lymphoma and the answer is D, 1 and 2. Correct? Easy? Now, the image of this Reed-Sternberg cell is also very important. See how this Reed-Sternberg cell looks like. Can you people appreciate? This is a cell which is binucleate. Can you people appreciate there are two nuclei with prominent eosinophilic nucleoli, and this cell, students, is called as the Reed-Sternberg cell, which has a owl's eye appearance, and this RS cell is CD15 and CD30 positive. These are the markers of the classical Reed-Sternberg cell, right? Now, what is important from this is this table. Any point from this table is very important. Every point for MCQ exams. Let us quickly revise this table. You all know that there are 5 basic types of Hodgkin's lymphoma according to WHO. One is the classical, another is a non-classical. The classical variety includes nodular sclerosis, mixed cellularity, lymphocyte rich and lymphocyte depleted, and non-classical is nodular lymphocyte predominant. This NEET is the non-classical, right? Now, let me quickly tell you the questions and the keywords which you have to pick up. Remember students, all types of Hodgkin's lymphoma are more common in males as compared to females, except for nodular sclerosis, which is equally present in males and females. Correct? Easy? So, one point which you have to focus. If the examiner asks you what is the most common type of Hodgkin's lymphoma in the Western world or in the world, then the answer is going to be nodular sclerosis. If he asks you what is the most common type of Hodgkin's lymphoma in India, then the answer is going to be mixed cellularity, right? Now, once the INI-CET examiner asks you which type of Hodgkin's lymphoma is never associated with Epstein-Barr virus, this EBV virus have been implicated in the pathogenesis of Hodgkin's lymphoma. EBV affects the B cells. Hodgkin's lymphoma is also a disorder of B cells, right? Basic things, right? Now, which is not associated, never associated with EBV? Answer is this one. Non-classical, that is nodular lymphocyte predominant. So, this is never associated with EBV. Second best answer is going to be nodular sclerosis, and these three, mixed cellularity, lymphocyte rich and lymphocyte depleted, are commonly associated with EBV. Understood? Next, the kind of Reed-Sternberg cells which you see in all of them. In nodular sclerosis, we see a type of Reed-Sternberg cell which is called as lacunar Reed-Sternberg cell. That is also a question. Lacunar RS cell. In these variety, we commonly see the normal Reed-Sternberg cell with the owl's eye appearance. And in the NLPHL, we see this type of Reed-Sternberg cell which looks like a popcorn. That is why this is called as the popcorn cell, the lymphohistiocytic variant. Understood? I'll show you the pictures of these in some time. Now, when I talk about the markers, the classical 4 types, that is these 4 types are called as classical because the Reed-Sternberg cells in them are CD15 and CD30 positive, right? Can you see? All these Reed-Sternberg cells are 1530 positive, whereas in NLPHL, the RS cell is 1530 negative. Remember that. So, what are the markers, students? CD20 positive, BCL6 positive and epithelial membrane antigen positive. Clear? Next, if I talk about the prognosis, if the examiner asks you which type of Hodgkin's lymphoma has the best prognosis, then the answer is going to be NLPHL. Second best, nodular sclerosis, and the worst prognosis is that of lymphocyte depleted. This has the worst prognosis, right? Another marker which you have to remember, students, is PAX5. This is also another marker for Hodgkin's lymphoma or Reed-Sternberg cell. Remember, PAX5 is a marker for B cell development, right? So, anything whenever it is given that PAX5 is there, you have to think that this is related to the development of B cell. T cell is not involved. Easy story, right? So, this table extremely important. Next, this is another picture of classical Reed-Sternberg cell which I wanted to show you. These are the normal lymphocytes, and can you people appreciate this looks like owl's eye? To a pathologist it does, right? So, this is a owl's eye appearance, the Reed-Sternberg cell. Then, another picture, students, can you people appreciate that this is one cell and there is an empty space or lacuna around that cell? That is why this is called as a lacunar Reed-Sternberg cell, right? And this lacunar Reed-Sternberg cell is seen in which type of Hodgkin's lymphoma? Nodular sclerosis Hodgkin's lymphoma, correct? Next, in this type, can you people appreciate that this cell in the center, it looks like a popcorn? Please, to a pathologist it does. We pathologists are very, very fond of food items and we start comparing this slide with the various food items, right? So, it does look like popcorn kernels. That is why we call this as a popcorn cell or a lymphohistiocytic cell, and this is seen in nodular lymphocyte predominant Hodgkin lymphoma, NLPHL. And the important point to take home is that this is called non-classical. Why? Because it does not give positivity with the markers CD15 and 30. What are the markers? CD20, CD45, BCL6 and epithelial membrane antigen. These are the markers which are positive. This can be a future exam question. If you are a FMG student watching this video, this topic of Hodgkin's lymphoma and the image of Reed-Sternberg cell is one of the most common questions, right? So whatever I have discussed here, you have to revise that. Correct? Easy? Let us move to the next question, students. Okay, this was an easy question from the first chapter of cell injury and adaptation. Senile atrophy is seen in, senile means aging, the atrophy in aging is seen in denervation, decreased nutrition, decreased blood flow or reduced blood supply. The answer here is reduced blood supply, because senile atrophy, students, a very common cause of that is ischemia and atherosclerosis of the vessels, right? When this happens, it leads to the atrophy, usually seen in the brain, can be seen in Alzheimer's disease, right? So this was a simple question, right? Next. Okay, identify the given instrument shown below. A very good question. You all know, I always tell you that the examiner will definitely give a question on any of the practical things, right? Like for example, the examiner has been giving a question on the needles. Previous year question this is. He has been giving a question on Sally's hemoglobinometer, which was asked in session 2, vacutainers, or Newbar's chamber, right, or the Turks or the Dacey's fluid, or even the ESR tubes, right? So these are the practical things which are definitely asked in one of the exams, right? Here the examiner gave this instrument and asked you what is the kind of needle. Now many students messaged me that ma'am, we got confused because all the 4 names which were given, they were of the bone marrow needle. I agree, this is one bone marrow needle, but students, Jamshidi needle, which is used for bone marrow, I've already showed you a picture. How does the Jamshidi needle look like? This is actually the Jamshidi needle, which is very different from the other needles. Why? Because it has a handle. Can you people appreciate the handle like this? You hold the needle by the handle and then put the probe inside, put the needle inside, right? So this is a very different needle which is used for the bone marrow, correct? And the advantage with this needle is that it can also be used to do the bone marrow biopsy. You can also do the biopsy with this, correct? So this is definitely not a Jamshidi needle which was given. So I have removed this answer. Now this needle which was given, it can be either Klima or Sala, because they are the other 2 common types. Remember students, I told you that Sala's needle has a side screw. Do you see a side screw here? No, I don't see a side screw here. See this needle. Can you people appreciate a side screw? S for Sala and S for side screw. So if you see a side screw in a needle, it will be Sala's needle. If you don't see a side screw, it is going to be a Klima needle. So the needle here was Klima needle. That is why this was the answer. Sala's needle has a side screw. Please remember this image, students. Can you people appreciate the side screw? This is Sala's needle. Jamshidi has a handle. So the needle which we are left with is the Klima needle. Islam is not the very common needle which is used, right? Now once the examiner asks you that what is the common site of bone marrow aspirator biopsy in adults, the answer is going to be iliac crest or posterior superior iliac spine. What is the common site for bone marrow technique in children? Then the answer is going to be shin of tibia or the anterior surface of tibia. Understood? Easy, right? So very common and important topic from practical hematology, students, that is the bone marrow needle, right? Let's move to the next question. Okay, carcinogen associated with clear cell carcinoma of the female genital tract. Now the image actually, even if they wouldn't have given, you would have directly marked the answer. What is the carcinogen which you associated with clear cell cancer? Direct question from the table which we have been showing you on chemical carcinogenesis. The answer is diethylstilbestrol, DES. Even when you see the image, can you people appreciate a lot of these clear cells which were there? Right, these are all the clear cells which are there. This image is basically a distractor which they have given you. So, clear cell carcinoma is associated with diethylstilbestrol, right? Remember students, I always show you this table of chemical carcinogens. Very important table students, and we have been noticing a lot of questions on this table, right? So, polycyclic aromatic hydrocarbons. All the Delhiites and people living in NCR are exposed to these polycyclic aromatic hydrocarbons because of the pollution, right? And all of us, that is why, are exposed to lung cancer. In Delhi NCR, we have seen a sudden rise in the cases of lung cancer because of pollution also, and decrease in life expectancy, right? So, what does this pollution have? Polycyclic aromatic hydrocarbons. These are the chemicals which they have. That is also a question. Then arsenic can lead to skin cancer. Asbestos is one of the potential questions which have been asked. So, remember in future exams also you can have a question on asbestos or ferruginous body image, right? Asbestos can lead to lung cancer. This is the most common malignancy caused by asbestosis, and malignant mesothelioma is the most specific malignancy which is caused by asbestos, correct? Aflatoxin, you all know, leads to hepatocellular cancer. Beta-naphthylamines or azodides, right? Bladder cancer. Benzene increases the risk of leukemia. Remember students, in NEET exam last year, 2021, this was a question which was asked from this table. A person has been exposed to benzene. Which is the cancer which the person is at increased risk of? The answer was leukemia, right? So, again a common topic which has been asked. Diethylstilbestrol, again a very important thing, clear cell carcinoma of vagina. Polyvinyl chloride, have you seen Mr. Narendra Modi has stopped the use of plastics. Plastic has got polyvinyl chloride, right? Now, polyvinyl chloride students, PVC, leads to increased risk of hepatic angiosarcoma. So, we should limit the use of plastics as much as possible. Why? Because it can lead to hepatic angiosarcoma, right? Then cadmium can lead to increased risk of prostate cancer. So, this table is also very important for all MCQ exams. Understood? So, this was also a very easy and direct question. Let's move to the next one. Which molecule helps the leukocyte to roll over the endothelial cells in the vessels? Very easy question students. This is a direct mugging up question which we have been telling you that any step of acute inflammation can be asked, right? Now, I have told you that what happens in acute inflammation, this neutrophil which is flowing inside the blood vessel in the lumen has to cross this membrane, go out and reach the site of inflammation, right? Site of infection. That is what has to happen, right? In this, there are a large number of steps. Now, they have asked you that which molecule will help in rolling over the endothelial cells in the vessels, right? To roll over the endothelial cells, right? So, which molecule helps in rolling? Rolling is mediated by which molecule students? Selectins. That is why the answer here is selectin, right? So, this is what I have been telling you. The first step in acute inflammation is early transient vasoconstriction. That is the earliest event. If the examiner asks you what is the most critical vascular event in acute inflammation, the answer is increased vascular permeability, correct? Then after that there is a stasis, that is the slowing of blood flow. After stasis, what will happen students? The neutrophil will start rolling over the blood vessel, right? After that, there will be a point where the neutrophil completely adheres to the endothelium. Then it crosses the endothelium and comes out. That is called transmigration. Then chemotaxis will happen. The neutrophil will go towards the site of infection, and then there will be phagocytosis, the engulfment of the microbe, right? Rolling is mediated by certain molecules which are called as selectins. Three types of selectins are there: EPL, Addition is mediated by certain molecules which are called as integrins. There are two types of integrins, beta 1 and beta 2. Transmigration is mediated by PECAM1 or CD31. Now, some students told me that, ma'am, the question was rolling over the endothelium, then the answer is going to be E-selectin. If they ask you that which molecule helps the leukocyte to cross the endothelium and come out, that is transmigration, then the answer was PECAM1, right? I don't know, because some students told me it was rolling over the endothelium, then the answer was selectin, and some students told me if that it was crossing the endothelium, then the answer was PECAM1, right? So this is direct mugging up which you have to do. You should know which are the chemotactic factors, which are the opsonins, how does phagocytosis happen. Understood? Easy? This was also a very common topic which is asked. Next question. Okay, match the following. Now, a very important, very recent trend which we saw was a lot of questions were asked on match the following in this INI-CET. Right? Match the following is a little easier one to crack and a very tricky one also, students, because the examiner tends to ask you a lot of one-liners in one question, right? So, even if you know 2 or 3 and you don't know one of them, you are good, right? You can solve the question. So, that's a good part about it, right? Now, it was a very, very basic question. Match the following. Kupffer cell. Where do you see Kupffer cells? You all know Kupffer cells are seen in the liver. So, A is 2. You are sure about that, right? Parietal cells. You all know parietal cells are seen in which organ? They are seen in the stomach. So, B is 1. Let us find out an option A2, B1. I can only see that one option, that is option D, is A2 and B1. That is why I can mark this as the answer, right? Now, let us see the other options. Some students said, ma'am, we got confused between dust cell and Clara cells. See, both dust cells and Clara cells are seen in the lung, but dust cells are basically pulmonary alveolar macrophages. So, they are seen in the alveoli. So, dust cells are seen in the alveoli. So, C3 and Clara cells are seen in the bronchioles. So, D is equal to 4. So, which option? Option D. So, that's what I am telling you. Whenever there is a question on match the following, do not get stressed about it, because even if you know 2 of them correctly, you might be able to solve the question. Easy, students? Very basic question. Okay. A 10-year-old boy with elevated platelet count, hemoglobin 9 gram per deciliter, MCV 60 femtoliters, MCH 20 picogram, serum ferritin of 185 microgram per liter, elevated lymphocyte and neutrophil. What is the type of anemia? They had given you the values and normal range for them, right? Now, there is a bit of controversy in this question, students, right? Some students told me that, ma'am, the ferritin level was 185. Now, serum ferritin, if it is 185, that means this serum ferritin is normal, right? It is not abnormal, neither it is decreased nor it is increased, right? And some students told me that, ma'am, serum ferritin was low, right? Now, they have asked you what is the type of anemia. When you see this profile of low hemoglobin with low MCV and low MCH, I know that my patient has got a microcytic hypochromic anemia. Do you remember the causes of low MCV and MCH, microcytic hypochromic? Remember this table which I used to tell you? Microcytic anemia, whenever the MCV is less than 80 femtoliters, you have to think about CETA. S for sideroblastic anemia, I for iron deficiency anemia, T for thalassemia, and A for anemia of chronic disease. Now, I know that in this question, because the MCV is low, I have to think about all these 4 things. Easy? That is how you are going to solve this question. Now, so that means sickle cell anemia is out. I have excluded this option. Now, my 3 answers can be anemia of chronic disease, thalassemia, or iron deficiency anemia. Now, if the serum ferritin is normal, right? Ferritin is the storage form of iron, which is always decreased in iron deficiency anemia, right? So, if serum ferritin was given as normal, the answer cannot be iron deficiency anemia, right? Here it is normal, right? Then I am left with 2 answers, students, anemia of chronic disorder and thalassemia, right? Now, even in thalassemia students, they would have given you something regarding electrophoresis or HPLC, right? So, I would say that I will go with this answer, that is anemia of chronic disorder. And if serum ferritin was low, then your direct answer was going to be iron deficiency anemia. Easy, students? Remember, I always show you this table, which is extremely important, students, and one of the most potential tables which are asked in the MCQ exams. The DDs of microcytic hypochromic anemia, how can you differentiate them on the basis of iron or ferritin or total iron binding capacity, peripheral smear, or some extra information, right? Iron deficiency anemia, serum iron will be low, ferritin will be low, of course, the body will try to utilize the iron stores. TIBC, the binding capacity with iron will increase, peripheral smear will show the presence of pencil cells, and RDW increases, there is thrombocytosis, and the Menzer index is greater than 13, right? Menzer index is equal to MCV upon RBC count. Remember, students, last year in 2021, there was a question on Menzer index, right? Where we had to utilize this Menzer index. This year, there was a question on DD of microcytic hypochromic anemia, right? Then when a patient has sideroblastic anemia, it is opposite to iron deficiency, remember. Iron will be more, ferritin will be more, TIBC will be less, peripheral smear will show ring sideroblasts and basophilic stippling, right? And also you can see Pappenheimer bodies in sideroblastic anemia, correct? If my patient has got anemia of chronic disease, the serum iron will be low. Why? Because which is the most important molecule in the pathogenesis of anemia of chronic disease? It is hepcidin, right? And hepcidin is a negative iron regulator, it decreases iron, right? But a very important factor to distinguish both iron deficiency anemia and anemia of chronic disease is ferritin, right? Ferritin level in anemia of chronic disease is either normal or it increases. That is why in this question, if the ferritin was normal, the better answer to mark is serum ferritin. Correct? The better answer to mark is anemia of chronic disease. Correct? TIBC is decreased, peripheral smear is normal, and ASR is usually increased. If the patient has got thalassemia minor or thalassemia trait, everything is normal, right? Except for the HbA2 increases on HPLC or electrophoresis, and Menzer index is less than 13. Another very important information you have to remember. Easy? Correct? Okay, let's move to the next MCQ. A patient with bare lymphocytic disease, graft versus host reaction does not occur due to. Okay, this was also a direct question which was not anticipated, students, but what I have realized is that immunodeficiency disorder is one of the potential topics which the examiner asked. Once they asked a question on ataxia, thrice they have asked a question on Wiskott-Aldrich syndrome, that is another immunodeficiency disorder, and this time they have asked a question on bare lymphocyte disorder. You just have to know that what happens in bare lymphocyte disorder, students, there is an absence of MHC class 2, right? So what is the answer here? MHC class 2 deficiency in lymphocytes. This is something, this type of immunodeficiency disorder can be asked. We were not anticipating, but it was also a direct mugging up question. What happens in bare lymphocyte disorder is there is an absence of MHC class 2. That is why this is the answer. Correct? Next. Okay. Which cytokine is not secreted by Th1 cells? Again, a very good question, students. In this exam, there were 3 questions on cytokines. That is why I always say cytokines are also very, very important, right? Now tell me which cytokine is not secreted by Th1 cells. You all know that T helper cell, students, can be of 3 types. One is Th1, another is 2H2, and third is Th17. Now let us revise immunity. Th1 produces IL-2, IL-12 and TNF alpha, right? Th2 secretes IL-4, IL-5 and interleukin 13. Th17 produces IL-17 and IL-22. Remember the basics which I told you? Now they have asked you which cytokine is not secreted by Th1. IL-12. IL-12 it is secreted. Interferon gamma, it is secreted. IL-2, it is secreted. IL-4 is basically secreted by Th2 cells. That is why the answer here is 4 only. It is not secreted by Th1 cell, it is secreted by Th2. All the other 3 options, IL-2, IL-12, interferon gamma is another one. All of them are secreted by Th1, right? Can you tell me the function of these? IL-4 students, remember I told you, activates the B cells to produce IgE antibody. IL-5, 5 is the E is the 5th alphabet. That is why it leads to the production of eosinophils. IL-13 leads to increased mucus production. That is why this is very important in the pathogenesis of type 1 hypersensitivity or bronchial asthma, the Th2 cell, right? Here the answer simply is 4 only, because IL-4 is not secreted, it is secreted by Th2 cells. Easy? Next question. An adult male patient presented with shortness of breath, hemoptysis and weight loss, right? Remember I told you students, if there is an elderly male with hemoptysis, right, what will you think about in your mind? One DD I always think about is lung cancer, right? On examination, hilar mass was present. Histopathological image is shown below. Immunohistochemistry revealed the presence of cells which were positive for P40. Oh my god, so many clues were given in this question, right? And students, again I'm reinforcing one more point. Remember, for the past 5 years I have been telling you that 2 things which are the mainstay of pathology diagnosis these days and are very important are stains and immunohistochemical markers. In the paper in session 1 and session 2, there were 6 to 7 questions directly on IHC. If you remember my table on IHC markers or the important IHCs, you would be directly able to answer those questions, right? So you will see, we have already done one question on Hodgkin's lymphoma markers. This is the next question which has come up, in which the examiner has given you that the patient has lung cancer. The history shows like that. The cells are positive for P40, right? And when you see this image, the image was also given. This was an image-based question. Can you people appreciate this pink island in the center? What is this? A lung cancer showing some pinkish material which is P40 positive. Just 3 points. What is the answer? The answer is squamous cell carcinoma of lung, right? So answer here is squamous cell carcinoma. This pinkish thing which I see is the presence of keratin pearls which are seen. Easy? Let us see the other options. Adenocarcinoma lung. Is adenocarcinoma lung positive for P40? No. Squamous cell carcinoma, the markers are cytokeratin, P63 and P40. These are the 3 important markers for SCC which you have to remember, right? For adenocarcinoma, if it was positive, the markers are TTF1 and napsin A. These are the markers. And students, the examiner was very smart. In the session 2, he asked a question on adenocarcinoma, the markers for adenocarcinoma, right? So another question on the markers. Easy? So this is not adenocarcinoma. Small cell lung cancer. Now in the same paper, there was another question on lung cancer which was small cell lung cancer. I'll just discuss. This was not small cell lung cancer, and this was also not large cell lung cancer, which is also a diagnosis of exclusion. Easy, students? Okay, let's move to the next one. A chronic smoker with 24 packs of cigarettes presented with breathlessness and chest pain. Again, this was another question in the same paper. Patient was a smoker with breathlessness and chest pain, a lung mass. Again, patient has a lung cancer. On staining, the cells are positive for chromogranin. Again, see the importance of IHC. The cells are positive for chromogranin. In which type of lung cancer the cells are positive for chromogranin? Come on. It is small cell lung cancer. That is why this was the answer. Small cell lung cancer. What is the most probable diagnosis? This. Why? Because any neuroendocrine tumor, students, in the body, whether it is carcinoid tumor, small cell lung cancer, any neuroendocrine tumor, is chromogranin, synaptophysin, and neuron-specific enolase positive. That is why this is the answer, right? Again, I am repeating for all of you, squamous cell carcinoma will be P40, cytokeratin, P63 positive, adenocarcinoma will be TTF1 and napsin A positive, small cell will be positive for NSC, synaptophysin and chromogranin, right? I have always told you students, lung cancers, all of them, there have been questions on mesothelioma, squamous cell cancer, small cell cancer, carcinoid tumor. Very, very important. Let us study them and revise them inside out, right? So this is a table which I have created in which you will be able to answer most of the questions, right? Most of the lung cancers are common in males except adenocarcinoma, which is more common in females, right? So female with a peripheral mass, with a non-smoker history, start thinking in terms of adenocarcinoma. So adenocarcinoma is peripheral, squamous cell cancer and small cell cancer are usually centrally located. That is why they give a history of a hilar mass, right? Now squamous cell cancer is smoking associated. The strongest associated with cigarette smoking is of small cell lung cancer. Adenocarcinoma is non-smokers. Large cells can be seen in both, right? Another keyword or history in the question can be of any of the paraneoplastic syndromes because lung cancers are associated with them, right? So SCC is associated with hypercalcemia due to PTHRP. Adeno is associated with migratory thrombophlebitis. Small cell associated with Cushing syndrome or SIADH, and large cell is associated with gynecomastia, right? When I talk about pathogenesis, squamous cell P53, adeno, KRAS, EGFR, ALK, small cell usually associated with LMIC, right? Squamous cell on microscopy, any squamous cell tumor is going to show you two things, students: keratin pearls, desmosomes. So keratin pearls were seen in this image. Adenocarcinoma will show glands. Small cell will show small cells with salt and pepper chromatin, nuclear molding and azopardy effect. All these points very important. Large cell will show large pleomorphic cells. And the last and the most important, which is a clincher for all of you, the squamous cell CK, P63 and P40 positive, adeno, TTF1 and napsin A, small cell NSC, chromogranin, synaptophysin, bombesin and CD56. These are the markers. These are very, very important, right? Let us quickly see all the images. Squamous cell shows the presence of these keratin pearls. Can you see? This will apply to squamous cell cancer anywhere in the body. Next, adenocarcinoma, of course, as the name suggests, will show glands, and these glands are lined by malignant cells. Bronchoalveolar carcinoma is a type of adenocarcinoma. Now it is called as adenocarcinoma in situ. It will show the tumor cells along the bronchoalveolar lining. Can you see? These are the bronchoalveolar lining and these are the tumor cells around them. So this pattern is called as the filigree or the lepidic pattern. Next, small cell lung cancer will show the presence of small cells. Some of the cells have got salt and pepper chromatin. They are strongly associated with smoking. This type of cancer has the worst prognosis, but one savior is that it is chemosensitive. It also shows maximum paraneoplastic syndromes like Cushing syndrome, correct? Now, the markers I have already told you, NSC, chromogranin, synaptophysin. One important thing on which I saw a question last year is the azopardy effect. What is azopardy effect, students? That in small cell lung cancer, what we see is the basophilic staining of the blood vessel wall. Can you see? This is a blood vessel. Can you people appreciate? This is a blood vessel. Why? Because I can see RBCs in the lumen, right? Now see the vessel wall. Can you see this vessel wall is basophilic? It is bluish purple in color. That's the basophilic staining of the blood vessels due to the presence of DNA, correct? And that effect is called as the azopardy effect. Understood? Okay, then we have the large cell cancer. Students, usually there is a the question is not asked upon large cell cancer because usually it is a diagnosis of exclusion and it is an uncommon cancer. What you will see here are large, highly pleomorphic cells, right? Then we have a carcinoid tumor, students, which is also very important. Again, Carcinoid tumor is also a neuroendocrine tumor. That is why the cells are going to show salt and pepper chromatin. And the other thing which you have to remember are the markers which are there for the same as the other neuroendocrine tumors, right? Then students, there are a large number of questions which are also asked upon malignant mesothelioma, right? That is another tumor. You all know it is one of the most specific malignancies which is caused by asbestos. Whenever a question is asked, there is a history of a construction worker or a person who has been working in a shipping industry, because shipping exposes to asbestos and that can lead to this cancer called as malignant mesothelioma, right? Now, in malignant mesothelioma, one question which was previously asked was the electron microscopy. The electron microscopy in mesothelioma shows the presence of long, slender microvilli as against a adenocarcinoma in which it shows short, stout microvilli. Easy? Right? So, these are all the lung cancers which we have revised and you should know them in detail, right? Let's move to the next MCQ. A very easy one from hematology students. Which of the following is not true regarding hemophilia A? Very basic question. You all know hemophilia A and B are X-linked recessive disorders. That is why they are more common in males as compared to females. That's the first point which I have told you. So, here one option is X-linked recessive disorder. This is true. More common in males. This option is also true. So, it cannot be the answer. What happens in hemophilia A students? Factor 8 deficiency. So, this is also true. What happens in hemophilia B? It is factor B. It is factor 9 deficiency. Correct? Fourth option is mucosal bleeding is seen commonly. This option is not true. That is why this is the correct answer, students. Mucosal bleeding is not seen commonly. What kind of a bleeding do you see in hemophilia A? We usually see major bleeding like hemarthrosis, right? Hemarthrosis, bleeding into joints or bleeding into cavities. So, you all know students, whenever I talk about hemostatic disorders, they are of two types. One is a bleeding disorder and another is a coagulation defect. Remember, I told you bleeding are usually male equal to female and coagulation are usually male greater than female because coagulation disorders are usually X-linked recessive. Correct? Next point, bleeding disorder mein a very important point which I always tell you is mucosal bleeding, minor bleeding. So, history will be of PTK, purpura, ecchymosis, right? Whereas in a coagulation defect, I see major bleeding like hemarthrosis, right? Bleeding into joints or bleeding into cavities. What are the other differences which I always tell you? If my patient has a bleeding disorder, then another keyword is the platelet count and bleeding time. They can be affected. But the coagulation tests like PT and APTT are usually normal. Whereas in a coagulation defect, usually platelet count and bleeding time are normal. I am saying usually, not in all the cases. Whereas PT and APTT can be abnormal depending upon the type of coagulation defect which is seen, the type of coagulation factor deficiency, right? So, this was a fairly easy question in which I am sure all of you must have written it correctly, right? Let's move to the next one. True about hereditary spherocytosis is. Now, this is a bit controversial question, students. Let us see the option and then I will tell you. True about HS. At least 25% cases have a family history of hereditary spherocytosis. I agree, because we say it is usually in 75% of cases autosomal dominant disorder. So, this statement is fairly true. High MCH is pathognomic of HS. This is totally wrong. Why? Because high MCH2 is not seen. What is seen? High MCHC. So, this is wrong. Gallstones develop by 4 to 5 years of age, right? Now, gallstones usually developed, I would say this is true as well as false. Again, not totally clear. Splenectomy does not protect against developing gallstones. This is false, because when you remove the spleen, it will prevent extravascular hemolysis. That is why it will prevent against developing gallstones, right? Does not protect is wrong. That is why this is also a false statement. So, if you have to mark true about HS, two options are at least 25% cases have a family history and gallstones develop by 4 to 5 years of age, right? Better answer to mark is at least 25% cases have a family history, because this is definitely correct, right? Next, an adult female is diagnosed with a gastric tumor, right, which on biopsy shows cells which are CD1117 positive but CK and S100 negative. Again students, another tumor and IHC, right? Again I am reinforcing IHC, please remember, right? Now let us start with the question keywords. First of all, my patient has a gastric tumor. Which all gastric tumors can happen? Which all cancers can happen in the stomach? There can be gastric adenocarcinoma, right? Then there can be gastrointestinal stromal tumor, and there can be a moltoma, right? Now these are the three tumors. Now let me tell you, here they have given the tumor is CD117 positive. If they have given CD1117 positivity, which gastric tumor is CD1117 positive? Direct answer students, the answer is GIST. Very good question students, the answer is GIST. If you know my IHC table, you will be able to solve this question. Answer is GIST. Adenocarcinoma is not the answer. Why? Because any adenocarcinoma will be cytokeratin positive. This is not CK positive, this is CK negative. Hodgkin's lymphoma, no, not there. It will be CD15, CD30 positive if it is there, and squamous cell carcinoma is also going to be cytokeratin positive. So what is the best answer here in this case students? Gastrointestinal stromal tumor. Had it been a moltoma students, the examiner would have given something in the history of H. pylori infection, because moltoma or marginal zone lymphoma is mostly seen if my patient has infection with Helicobacter pylori. Easy story, right? So whenever a GIST case comes students, grossly it will show the presence of soft, well circumscribed lesion, right? What I see is a soft, well circumscribed lesion, and on IHC you can see three markers are important students. CD117, also called as c-KIT, that is the most sensitive marker, remember. Then there is a very specific marker that is called Dodge1, most specific marker, and even some cells are CD34 positive. These are the three markers which you have to remember. Grossly well circumscribed lesion. If you ask me microscopically, you will see two types of cells, spindle cells and epithelioid cells, right? More common are the spindle cells, correct? Then another thing which you have to remember regarding GIST is that it arises from which cell students? The interstitial cells of Cajal or the gut pacemaker cells, and 95% of patients are c-KIT positive. They are c-KIT positive. Easy, right? Lastly students, in future exams they can ask you this Fletcher's classification for the prognosis of GIST. So they say the prognosis of GIST depends upon two things students: the size of the tumor. If it is less than 5 centimeters, it is fine. If it is more than 5 centimeters, it's not good prognosis. And the mitotic activity, if it is less than 5, it's okay. If it is more than 5, it's not okay. It has a poor prognosis, right? So next exam, in the future exams, they can ask you a question that what are the two important features on which the prognosis of GIST depends? The answer is size and the mitotic activity. Clear? Next MCQ. Okay, direct spotter, which I have been posting so many times on my Instagram handle as well. If you know this image that this is the spotter, you would have directly answered the question without even reading the history, right? What is this students? These things which you see, the purplish basophilic inclusions which you see, this is basically molluscum contagiosum, direct spotter. Let us see the history. Child presents with multiple skin lesions over the inner thigh and genital areas. It initially started as macule and later developed nodules. Some nodules have central umbilications, right? So, two important things in a case of molluscum contagiosum, umbilicated nodule. In this image, can you people appreciate? these nodules will show central umbilication, right? That is very important. And on microscopy, can you people appreciate these inclusions which are seen in the stratum spongiosum, I'm sorry, mostly. So these are basically called as the Henderson-Peterson bodies, right? What is the answer here? Henderson-Peterson bodies, right? Donovan bodies are seen in leishmaniasis. Multinucleated giant cell and Zhang cell are seen in HSV infection, and coilocytes are seen in human papilloma virus infection. That can be a future exam question, right? So very important and easy spotter which was asked was molluscum contagiosum, right? Next, a patient has WBC count of 4.5 lakh with eosinophilia, basophilia, neutrophilia. What is the diagnosis? If your hemat basics are correct, students, there is no way you cannot answer this question. They have told that the patient's WBC count is 4.5 lakhs. What is the normal TLC, total leukocyte count? It is 4,000 to 11,000 per cubic millimeter. That means my patient's WBC count is very high, along with the patient having eosinophilia, basophilia, neutrophilia, right? What is the diagnosis? Direct answer, students, CML, chronic myeloid leukemia, which is a myeloproliferative disorder. Remember, I told you, whenever you hear about basophilia, start thinking about CML, right? CLL, what will you see? It is a lymphoproliferative disorder. So you will see mature lymphocytes plus the presence of smudge cells. There was a question on smudge cells in the same paper, right? If my patient has got AML or ALL, more than 20% blasts will be seen on the peripheral smear. Here, direct answer was CML. Very, very important topic, students. All leukemias are very commonly asked. Now here, you all know in CML, patient has got T922 translocation or Philadelphia chromosome, which leads to constitutive activation of tyrosine kinase. That is why the treatment is imatinib mesylate, which is a tyrosine kinase inhibitor, correct? This is also very commonly asked in the exam, students. The diagnostic criteria for CML in the accelerated phase. You all know there are three phases: chronic phase, accelerated phase, and the blast phases. One important criteria is the blast count. If the blast count is less than 10%, it is chronic phase. If it is between 10 to 19%, it is the accelerated phase. If it is more than equal to 20%, it is the blast crisis, right? What are the diagnostic criteria for CML in accelerated phase? Asked twice in the exam, so you have to remember all of them. The blast 10 to 19%, peripheral blood basophilia more than 20%, persistent thrombocytosis or thrombocytopenia, increasing spleen size, and T922 translocation. Everything is unresponsive to therapy. You are giving therapy to the patient is not responding, right? Then the peripheral smear starts looking like a bone marrow. It is a myeloproliferative disorder. Again, I am revising. For FMG also, this is a very important topic, right? Because it is a myeloproliferative disorder, you will see all stages of myeloid maturation like promyelocytes, myelocytes, metamyelocytes, band forms, neutrophils, eosinophils, basophils in the peripheral smear, correct? The bone marrow will show the presence of pseudo-Gaucher cell, a cell which looks like a Gaucher cell with a crumpled tissue paper appearance, but not seen in CML, not seen in Gaucher's disease, but seen in CML. That is why it is called as a pseudo-Gaucher cell, right? Then, when you do the fish analysis, that is another future picture which I am showing you. You will see T922 translocation. See, they have told you that red is 9, ABL, green is BCR, and it is 22. Now, this is a normal patient in which we see 2 green and 2 red. And here, when you see, there is a fusion of red and green. See, can you people see? Here, there is a fusion of red and green. That means translocation occurs. So, this is basically T9:22 translocation. All the future prospective questions regarding CML we have discussed, right? Then, students, this was another MCQ, one of the favorite topics for the examiner. That is cellular aging. So they asked which of the following statements are true regarding sirtuins, right? Sirtuins increase the insulin sensitivity and thus glucose metabolism. Absolutely correct. Promotes genes which increase the longevity. Yes. There are 7 types. Absolutely right. They are a type of histone deacetylase. Absolutely right. So what is the answer? 1, 2, 3, 4. All of these statements are correct. Very important topic, students. Sirtuins. What are these sirtuins? They are NAD dependent protein deacetylases. Approximately 7 types are known. They increase the longevity. Research is going on and it has been seen that they are the molecules which will increase the longevity or the lifespan, right? They have a role in diabetes, mellitus, cancer and aging. Again, a future question. And calorie restriction increases the lifespan. That is why it decreases cellular aging. This was a question in the May 2022 INI-CET exam. So they asked a tricky question, which of the following will increase the lifespan? And one of the options was calorie restriction. Studies are going on, students, and they have said that calorie restriction, if you restrict your number of calories, it will increase your life years or longevity, correct? So very important topic, students, cellular aging. Please do not miss this topic because it is asked every year. The other 2 questions which are asked from this topic are: 1, Werner syndrome, which is a syndrome of premature aging due to a defect in DNA helicase. This was asked 4 years ago, right? Another was Hayflick limit, which was a direct question 2 years back in your INI-CET exam, right? So Hayflick limit is normally the cells will undergo approximately 60 to 70 cell divisions in their entire lifespan. One cell will divide approximately 60 to 70 times in its lifespan and then it will die, right? Another concept which you have to remember is telomerase and telomere. That is also asked commonly and can be asked in the future. What are telomeres, students? So they say they are short repeat sequence of nucleotides which are present at the ends of chromosome. Suppose this is one chromosome. At the end there is a sequence. Suppose it is TTAGGG. That is called as a telomere. What is the significance? So it is present at the end. With every cell division it will keep on shortening and ultimately cell will die when telomere disappears. So in short, telomere shortening will lead to cellular aging, and there is an enzyme which is called as the immortality gene which will inhibit cellular aging. Why? Because it will keep synthesizing the telomere. So cell will not age, the cell will not die. So another practical question, application based question which they ask you is that, which cell has got maximum telomerase activity? What you will write? Cancer cells, right? So cancer cells have got a lot of telomerase activity. Then you have germ cells also have got a lot of telomerase activity, and somatic cells do not have much telomerase activity. Easy? So this question on sirtuins was also quite expected and fairly a easy question. Let us move to the next one. Match the following stains on the tissue. Again a very easy one, students. I have been telling you that stains are very, very important. Prussian blue stain, come on. Iron or hemosiderin, Prussian blue. So 1 matches with A, right? So 1 matches with A. Done? You don't have to see the other options also. That's why I say match the following is easy. Pass with glycogen. So 2 matches with B. Again, this serves the purpose. Congo red stain is for amyloid. So 3 matches with C and 4 matches with D, right? So the answer here is 1A, 2B, 3C and 4D. That's the answer. Correct? Easy? So there is a very important table, students, which I have been showing of important stains in pathology. I'm showing you this table here. Please remember this table, right? Please do this table from the videos or from this module, and remember, because it can be asked as a part of clinical pathology question or any of the match the following, or any image can also come, right? So this is the table and everything is covered. In session 2, there was a question, how will you measure iron in the body or tissues? How will you measure with stain? Prussian blue or pearl stain, right? So there was a question on stain in session 2 as well. Easy? Okay. Next MCQ. The given peripheral smear is associated with which leukemia? So, you were given this peripheral smear. Come on, tell me which leukemia is present. What do you see in this peripheral smear? Can you see these cells which I see? They are the normal lymphocytes. But what is important for me is these cells, students. What are these cells? Remember, I have shown you this image so many times. What are these cells, students? These are actually smudge cells. And smudge cells are seen in CLL. I just discussed with you some time back. So, what is the answer here? CLL, because smudge cells are seen in them, right? So, just one image regarding CLL which I want to show you. It's here. Usually seen in elderly people, associated with deletion of 13q, 11q or 17p. My patient will present with painless lymphadenopathy, or in addition there can be a history of any autoimmune hemolytic anemia. The absolute lymphocyte count is greater than 5000 per millimeter cube, which is a very important diagnostic criteria. This is important. Peripheral smear which shows smudge cells. Some people cell they look like baskets, so they called it as a basket cell. These are all smudge cells which I have marked, right? Some people said it looks like a parachute, so they told it looks like a parachute. It is a parachute cell, right? On lymph node biopsy, we see proliferation centers which are actually pathognomic of this disorder. And a very important thing which we do for the diagnosis of CLL these days, can be a future question, is the markers. The cells are CD5 positive, 23 positive and CD200 positive. These are the three markers, can be given as a keyword in a clinical pathologic question. It is also a very important point to differentiate them from mantle cell lymphoma, right? Mantle cell lymphoma is CD5 positive and CD23 negative. Easy? Okay, next move to the next MCQ. Which of the following is not associated with poor prognosis of BALL, right? Remember, I told you one table of the prognostic factor of ALL. So, see in this session only, students, we got a question on ALL, the prognostic factor, very, very important. We got a question on the image of CLL, and we got a question on the smear of CML. So, all three leukemias examiner asked, and all of them were easy, right? Fairly simple and expected question. Now, first let us see this table and then I'll go back to the question. Which of the following is a good prognostic factor? So, good prognosis are age 2 to 9 years. Females are good prognosis. Whites is good prognosis. L1 type is good prognosis, whereas L2 and L3 type is bad prognosis. BLL is good, TLL is bad. Any of the organ involvement like CNS or testis or spleen is a bad prognostic factor, right? Cytogenetically, hyperdiploidy is good, hypodiploidy is bad. Translocation 922 is bad. Trisomy 4710 is good. And if the TLC is less than 1 lakh, it is good. If it is more than 1 lakh, it is bad. Now, let us go back to the question. Which of the following is not associated with poor prognosis? That means, this is a very tricky line, not associated with poor prognosis. That means, which of the following is associated with good prognosis? T11 protein, let's wait. Hyperdiploidy, good prognosis. T922, bad prognosis. Age less than 1 year, bad prognosis. T1114, bad prognosis. That is why the correct answer is hyperdiploidy, right? Now, some students told me that this question was asked in session 1. Some told me it was asked in session 2. In whichever session it was asked, it was a fairly expected question, and this is how you have to solve it, right? Let's move to the next one. Okay. A 19-year-old female presents with midline neck swelling that moves on deglutination, and on ultrasound a 2 cm into 2 cm nodule in the left lobe of thyroid extending into strap muscle. Again, a neck swelling which is moving with deglutination. I know it is a thyroid lesion. They have told you that a 2 cm thyroid nodule is seen which is extending to the strap muscle. Histopathologic image is given below. What is the most likely diagnosis? Now, my students told me that the image showed papillary projections, right? Therefore, students, the answer was papillary carcinoma of thyroid. This is one of the most important images which is asked by the question. I don't know why, but it is examiner's favorite, the orphan Annia nuclei, right? Let us quickly revise them. This is the table which I have. Most common thyroid malignancy is papillary, least common is anaplastic. Whenever there is a papillary cancer, there can be a history of radiation exposure, thyroglossal cyst or Hashimoto's thyroiditis, and in follicular, iodine deficiency or multinodular goiter, right? All the thyroid cancers arise from follicular cells except for medullary, which arises from the parafollicular cells, right? Papillary cancer usually metastasizes by lymphatics. That was also asked once. Follicular usually metastasizes by hematogenous. That was also asked once, right? Now, papillary usually associated with BRAF or red PTC mutation. Follicular associated with KRAS or PI3K. Medullary associated with RET or MEN2. And anaplastic is associated with P53 mutation, right? If you ask me what cancer has the best prognosis, papillary. Which has the worst prognosis? Anaplastic, right? And when I talk about histopathology, let me show you the picture, students. This is the histopathology of papillary cancer. Can you people appreciate? The cells will be there in papillae. 5 things you have to remember. Cells in papillae. Second, I see nuclei which are totally empty. Can you see totally empty nuclei? These nuclei are called as orphan Annia nuclei because they look like the eye of this cartoon character. 2 other things which you see is nuclear inclusions and coffee bean nuclei. Then in the one other thing which you see is the presence of Samoma bodies. Okay? So this is what you see in papillary cancer of thyroid. When I talk about follicular cancer of thyroid, students, one thing which is very important is capsular and vascular invasion. Capsular invasion, vascular invasion. That is very important when you see the biopsy or the tissue specimen. That is why, students, FNAC is not diagnostic. FNAC cannot be used in the diagnosis of follicular cancer, right? When I talk about medullary cancer, the thing which you have to remember is amyloid. Can you people see this pinkish material in the biopsy? So this pinkish material is basically amyloid. If a thyroid cancer shows a lot of pink material and associated with Men's syndrome, the answer is amyloid. Understood? Easy. And lastly, this is the apple green birefringence which is there, which you will see with amyloid. In session 2, there was a question on medullary cancer of thyroid, right? Next question, maximum amplitude in thromboelastography image, right? Now, thromboelastography is one of the potential topics, students. Again, a topic which was asked in the previous years. Thromboelastography. You know, this is the image of thromboelastography. This is the graph which is there. What is the function of this technique, thromboelastography? It is the assessment of the efficiency of the coagulation system. How efficient is the coagulation system? Usually, this technique is used in emergencies or ICU to see the efficiency of the coagulation system, right? Now, this is the graph. The first part, that is half of it, will see the coagulation and half of it will see the assessment of the fibrinolysis. How well is it working, right? Now, this R which is here is the reaction time, and it is the function of the clot formation. How well is the clot forming? Then we have K, which is the achievement of certain clot firmness. It basically assesses the conversion of fibrinogen to fibrin. How firm is the clot, the efficiency of clot, right? And then we have here how the maximum amplitude is the maximum strength of the clot. Can you see? This is the maximum amplitude, MA. This is the maximum strength of the clot, which depends upon how well the platelets and fibrins have interacted with each other. Here the question was, maximum amplitude in thromboelastography will depend upon what? It will depend, of course, on platelets. That is why this is the answer. Correct? Let's move to the next question, students. Which of the following are true about familial adenomatous polyposis? Again, a very good question, students, and straightforward. It is autosomal recessive. Is it autosomal recessive? No. We all know it is autosomal dominant. If FAP is not treated, 100% of the cases progress to adenocarcinoma of colon. This is absolutely true. So, one option which is true is this. It is associated with a gene mutation in KRAS. Absolutely wrong. It is associated with APC gene mutation on chromosome number 5. It is associated with congenital hypertrophy of retinal pigment epithelium. That is also true. So both these statements are true regarding PAP. Correct? Next question. Which of the following is true about proto-oncogene? Again, students, remember a proto-oncogene table which I told you. You have to tell which is true. Now, KIT decreases the expression of GIST via tyrosine kinase signaling pathway. Is c-KIT mutation seen in GIST? Yes. KRAS mutation is more commonly associated with small cell lung cancer. Actually, KRAS is usually associated with colon cancer and pancreatic cancer, not with lung cancer. With small cell lung cancer, a more common mutation is LMYC. Remember I told you? So this statement is false. ERB2 is overexpressed in association with breast cancer. Absolutely correct. What is ERB2? It is also called as HER2/neu. You all know HER2/neu is associated with breast cancer. This statement is absolutely correct. PDGFRB, it has suppressed expression in colorectal cancer. It is wrong. PDGFR is associated with astrocytoma. Please see the table which I have told you, right? So this is also wrong. So what is the statement which is correct? ERB2 expression is overexpressed in breast cancer. Correct? And also KIT decreases the expression of GIST. Correct? Next, a child with neurological problems, the bone marrow biopsy is given below. What is the most likely diagnosis? Again, students, for the past 4 years, one of the favorite topics for the examiner is the Gaucher's disease and the Gaucher's tell. Again, a broad topic which you have to revise for all MCQs exams is storage disorders. Storage disorders. Clear? So what do you see in this bone marrow, students? Can you people see these cells? Don't you see that the cytoplasm look like as if you have crumpled a tissue paper? So this is called as a crumpled tissue paper appearance of cytoplasm. This is actually, students, a Gaucher's cell which is seen in Gaucher's disease, and it is due to glucocerebrosidase accumulation. This is PAS and oil redo positive, right? So what is the thing which is inside? Glucocerebroside. Very important question and topic, right? So students, these are the questions which are asked in session 1. I have not included the overlapped ones. They were also there, but these are very, very important and common topics which you should know in detail, right? Let us move to the session 2 now, students. In session 2, the topics which were asked, again, from cell injury we had calcification, cytokines questions and stains, again expected. Hematology, we had microcytic hypochromic anemia, retic count, match the various cells. Practical hematology, one question which was Sali's hemoglobinometer. Langerhans cell histiocytosis and hemolytic anemia. Again, very anticipated questions. From systemic pathology, one question on lung cancer. So in session 1, we had a question on small cell and squamous cell. Here adeno. Molluscum contagiosum, the same image was asked. Thyroid cancer, medullary was asked here. Papillary was asked in the previous paper. Molecular classification of breast cancer. There was a question on Men's syndrome and gastric adenocarcinoma, right? Let us see the questions. 35-year-old women presents with fatigue. Hemoglobin 5 gram percent, MCV very low, 24. Ferritin level low, low MCV. Leukocyte count 11K, which is normal. Platelet count a bit high, right? The peripheral smear is given below. What is the diagnosis? Very easy, students. Microcytic hypochromic anemia. I have told you what are the DDs? CETA. Here my patient's ferritin is also very low, MCV very low. Peripheral smear showed the presence of these microcytic hypochromic cells along with pencil cells. So what will you mark, students? I will mark the answer as iron deficiency anemia. Easy? So out of CETA, sideroblastic will have everything high. Iron deficiency, this fits in. Thalassemia, the things are going to be normal and you will see target cells. Anemia of chronic disease, the MCV cannot be this low and the ferritin level has to be normal or increased, right? So here I come to a diagnosis of iron deficiency anemia. Is that clear? Okay, another question from hematology, quite expected. Hemoglobin of the patient is 5, absolute retic count is 9%. Calculate the corrected retic count. You all know what is the formula for corrected retic count? that is equal to patient's retic into patient's hemoglobin or hematocrit upon the normal hemoglobin or hematocrit for that particular age, right? Here the retic count is 9%, into patient's hemoglobin is 5, normal hemoglobin is considered as 15. So what will be the answer, students? My answer will be 3%. This is the answer which I have come to. This is also a very common question. So regarding retic, students, the image of the retic, right? You all know how does a retic appear? This kind of a cell. On the supravital stain, you will see DNA or histones being stained like this, right? So this is how reticulocyte will look like. What is the stain? What is the normal retic count? In what conditions is it increased? These are the common questions which you have to remember. Correct? Next, metastatic calcification can be seen in all these conditions except, right? Renal failure. Do you see metastatic calcification? I see. Vitamin D disorders, I see. Metastasis in the lymph node, I don't see metastatic calcification, I see dystrophic calcification in a lymph node, right? Hyperparathyroidism also shows metastatic calcification. That is why this is correct. This is the answer. Again, students, calcification is one of the most important topics. It is of two types, dystrophic, metastatic. Dystrophic occurs in dead tissues, metastatic occurs in living tissues. D for dystrophic, D for dead. That is why in a dying tissue, the serum calcium has to be normal. In metastatic, there is hypercalcemia. In dystrophic, there is RAT. That is, it is seen in rheumatic vegetations, atheromatous plaque, and tubercular lymph node or metastatic lymph node. Along with that, Samoma body is an example of dystrophic calcification. Metastatic is seen wherever there is increased calcium, like bone diseases, vitamin D disorders, sarcoidosis, milk alkali syndrome, hyperparathyroidism, right? The options which were there in this question. Easy? Then, image of Samoma body. Students, this is how a Samoma body looks like. It is a foci of dystrophic calcification. You should know these DD, students, which are very important, in which all conditions you will see the presence of Samoma bodies. Any papillary cancer like thyroid or renal cell, any papillary cancer will show Samoma bodies along with meningioma, serous adenocarcinoma of ovary, prolactinoma or mesothelioma, right? Next, a chronic smoker presents with a lesion. Mass is noted at the lower lobe in the periphery of the lung. Remember in the table I showed you adenocarcinoma in the periphery. Diagnosis of adenocarcinoma is made. We have already discussed in that table. The biopsy will be positive for which marker, students? TTF1 and napsin A. These are the two answers. P40 will be positive in squamous cell cancer. Chromogranin will be positive in small cell cancer. Correct, easy? Next, match the following. Again a question on cytokines, very important. IL-4, I told you, activates B cells to produce IgE. So IL-4, 1 goes to C. IL-5, I told you, E, fifth letter, eosinophil. So 2 is A. IL-9, students, that is 3, it is related to mast cells. So 3B. And 4 IL-13 is associated with D, that is dendritic cells. Easy? Next, iron in tissue is stained by, again a direct question, students, Prussian blue, right? We have already done in the table. Hereditary angioneurotic edema is due to deficiency of, again a very direct question, students, from the table which I have told you in inflammation chapter. It is associated with C1-INH, C1 inhibitor. What is associated? Hereditary angioneurotic edema, right? Very important. Next, man or woman presents with lesions on inner thighs or perianal region. The lesions are nodular with size 4 to 6 mm. The image is shown below. Again a similar image, students. What will be the diagnosis? We have done a similar question in the past. The diagnosis is molluscum contagiosum, was asked in the session 1 also. Next, match the following histological finding with the tumor. Popcorn cell, we just discussed. Where do you see popcorn cell? NLPHL. So, popcorn cell, NLPHL. Fagot cell seen in AML M3. Sézary cell, cerebriform nuclei, mycosis fungoides, cutaneous T-cell lymphoma. Starry sky appearance, Burkitt's lymphoma. Matching done. Very important question. All these things can be asked. Let us see the images of all of them. Fagot cell. What is a fagot cell? Criss-cross arrangement of all rods in a myeloblast. Popcorn RS cell we have already discussed. This is the starry sky appearance seen in Burkitt's lymphoma. Again, a very important picture and a very important topic for all MCQ exams, right? Then students, this is a picture of a Sézary cell which is seen in Mycosis fungoides. What is the principle of the instrument shown below? What is this, students? Now, I have been telling you and showing you this instrument in all my videos earlier. This question was never asked, but I always anticipated that it will be asked. And this time it was asked. This is a Sally's hemoglobinometer. Sally's hemoglobinometer, not used these days for the assessment of hemoglobin. But what is the principle, students? Hemoglobin is converted into acid hematin, right? And the answer therefore is acid hematin. Direct answer is acid hematin, right? Then students, a 7-year-old child with fever, erythematous rash, bone pain, X-ray skull shows multiple lytic lesions. The skin biopsy shows prominent nuclear grooves with eosinophils. Image shows, image was probably shown, I don't know clearly whether it was shown or not. IHC was CD1A S100 positive, right? Again, students, if you know the IHC markers, you would be able to directly solve this condition. A child with bone pain, rash, lytic lesions. Whenever we think about lytic lesions, we think about multiple myeloma, right? Does this child have multiple myeloma? I don't think so, because why will it show nuclear grooves with eosinophilia and CD1A positivity? CD1A positivity is seen in Langerhans cell histiocytosis. That is why this is the answer. Now, LCH is also one of the topics which has been consistently commonly asked these days, right? So, let us quickly revise it. It is a proliferation of immature dendritic cells associated with BRAF V600E mutation. The biopsy will show coffee bean nuclei. See, this is the image of coffee bean nuclei which you see, right? And on electron microscopy, which is also asked in the exams, can you people appreciate this? It shows Burbeck granules. It shows the presence of Burbeck granules and the presence of tennis racket appearance, right? So, Burbeck granules and tennis racket appearance is seen in, answer is Langerhans cell histiocytosis, and the markers are CD1A, S100 and Langerhans positive. Correct? Easy? Next, a child with hemolytic facies, splenomegaly and history of recurrent blood transfusions. Now, if you are given this history that my child has hemolytic facies, recurrent blood transfusions and splenomegaly, what is the diagnosis which you come to? I make a diagnosis of beta thalassemia major. Remember, I told you the patient has got thalassemic facies because of extramedullary hematopoiesis, and also the patient has recurrent blood transfusions. So, that is the diagnosis. What all investigations will you do? I will do a peripheral smear definitely to see the presence of target cells and other things. I will do a HPLC for diagnosis. I will not do a bone marrow or a PT-APTT. So, what is the answer, students? A and B. A very direct and easy clinical question which was given, right? You will not do a bone marrow or coagulation test in this patient, correct? Next, identify the thyroid pathology. The biopsy finding was given, right? So, can you see in this thyroid, you see this pinkish thing? I have already showed you the images. What do you think it is? Medullary cancer of thyroid. Easy? Next, a 49-year-old female presents with a breast lump. Which of the following findings is in accordance with basal-like breast cancer? You know what is basal-like breast cancer? It is ER-PR HER2/neu negative, right? So, whichever is ER-PR HER2/neu negative, that is D, that is the answer. Basal-like is ER-PR HER2/neu negativity, that is called triple negative breast cancer. Now, we have been emphasizing, both me and Dr. Rohan have been emphasizing the fact that the molecular classification of breast cancer is very commonly asked in your exam. Every year we see a question, and this time it was asked again. Now, from molecular classification from pathology, you should know this much, that ER-PR ER-PR positive but HER2/neu negative, right? That is called as luminal A, right? When it is ER-PR HER2/neu positive, that is called luminal B or triple positive. When it is HER2/neu positive only, it is called HER2/neu positive. And when it is all three markers positive, it is called basal-like. You should know how to interpret the IHC also, which I have discussed with you a number of times, right? Next, which of the following is associated with MEN2A syndrome? Again, a very common topic, students, MEN syndrome, right? MEN2A is also called as Sippel syndrome. Which thing is seen? Parathyroid hyperplasia, absolutely correct. Medullary thyroid cancer, absolutely correct. Cafe au spots, no. Where do you see cafe au spots? NF1. Optic nerve glioma, no, right? So the answer here is MEN2A syndrome, right? So a lot of direct questions in session 2 as compared to session 1, but the difficulty level was almost similar and the topics were also similar, right? These were the questions of pathology from the INI-CET November 2022 students. All these topics are extremely important. Again, students, the stain and IHC marker table, please revise them with all these topics again, right? At the end, students, I would just like to say that success doesn't just come and find you. You have to go and get out for it, right? So basically, you have to work very hard. Persistence, perseverance and consistency are very important for cracking any of the MCQ exams or doing good in life, right? So please, students, keep on revising because revision is the key. You have to find and go and get the success. The success is not coming to you in an easy way, right? At the end, I hope you enjoyed this video. Thank you so much, everyone, and all the very best.